Welcome everyone to this presentation on drugs used to treat cardiovascular disorders. We'll be exploring the medications that play a crucial role in managing these conditions. The cardiovascular disease continuum illustrates how risk factors progress to serious conditions. Understanding this progression is key to preventative care and effective treatment strategies. It starts with conditions like hypertension and high cholesterol, and if left unchecked, can progress to heart failure, myocardial infarction, and stroke. This concept shows us why early intervention with medications is so important. Today, we'll begin by focusing on drugs specifically designed to manage hypertension, a very common cardiovascular condition. Nearly half of adults have elevated blood pressure, often without symptoms. So, identifying and treating it early with medication can reduce the risk of severe complications. Our first learning objective is to understand how blood pressure is physiologically regulated. We'll explore the roles of both the nervous and endocrine systems. The nervous system uses baroreceptors and chemoreceptors to monitor blood pressure and make quick adjustments. Meanwhile, the endocrine system uses hormones like ADH, aldosterone, and catecholamines to maintain long-term control. We'll delve into the specific components of the nervous and endocrine systems that influence blood pressure, including receptors and hormones. Baroreceptors in the aorta and carotid sinus sense pressure changes. Chemoreceptors detect changes in oxygen, CO2, and pH levels. The vasomotor center in the medulla sends signals that adjust vessel diameter. Let's review some key terms related to cardiac function. Understanding these terms is essential for grasping how medications affect the heart. Terms like preload, volume in the ventricle before contraction; afterload, resistance the heart must overcome; contractility, strength of contraction; and inotropic effect, effect on contractility, help explain how drugs work. Blood pressure is influenced by cardiac output, peripheral resistance, and blood volume. We'll analyze how each of these factors impacts overall blood pressure. Cardiac output is the amount of blood pumped per minute. Peripheral resistance is how tight or wide the blood vessels are. Blood volume is the amount of fluid circulating. Medications target these areas to lower blood pressure. We'll synthesize the factors that contribute to high blood pressure and discuss the long-term consequences of leaving hypertension untreated. If untreated, hypertension can damage blood vessels and organs like the brain, heart, kidneys, and eyes. It can also double the risk of cardiovascular disease for every 2010 MHE increase after 115/75. Many factors can elevate blood pressure. We'll explore some common dietary, lifestyle, and medication-related causes of elevated blood pressure. Common triggers include high sodium intake, obesity, stress, smoking, alcohol, oral contraceptives, NSAIDs, and certain antidepressants or stimulants. The American Heart Association provides clear guidelines for blood pressure categories. We'll review these categories to understand the stages of hypertension. Categories include normal, 120/80, elevated, 120/129/80, stage 1, 130/139/80/89, and stage 2, 140/90. Untreated hypertension can damage vital organs. We'll discuss the impact of high blood pressure on the brain, heart, eyes, kidneys, and peripheral vasculature. Think of hypertension like high-pressure water in a garden hose. It damages the walls over time, leading to stroke, heart attack, kidney failure, or vision loss. Hypertension is defined as persistently elevated blood pressure. The goals of drug therapy are to reduce cardiac output, relax smooth muscle, and decrease blood volume. As healthcare professionals, we play a vital role in patient education. We'll discuss lifestyle modifications that patients can adopt to manage cardiovascular disorders. DASH diet, limiting alcohol, increasing exercise, stopping smoking, reducing stress, and cutting down sodium intake are cornerstones of non-pharmacological management. Antihypertensive drugs work through various mechanisms. We'll explore how different drug classes target specific physiological processes to lower blood pressure. Some reduce fluid volume, diuretics; others relax vessels, vasodilators, or block hormone effects, ACE inhibitors, ARBs. There are many classes of drugs used to treat hypertension. We'll provide an overview of the different types of medications available. The renin-angiotensin-aldosterone system plays a crucial role in blood pressure regulation. We'll examine how ACE inhibitors and ARBs affect this system. Think of RAAS as the body's emergency water and pressure control system. When blood flow to the kidneys drops, renin is released, eventually forming angiotensin II, a powerful vasoconstrictor, and aldosterone, which retains sodium and water. ACE inhibitors block the conversion of angiotensin I to II, while ARBs block its action directly. Both reduce BP and the strain on the heart. Let's take a look at specific ACE inhibitors and ARBs, including their dosages and potential adverse effects. ACE inhibitors often end in pril, like enalapril or lisinopril, while ARBs end in sartan, such as losartan or valsartan. Common side effects: a dry, persistent cough for ACE inhibitors, and for both classes, hyperkalemia and risk of angioedema. Which class can cause that nagging dry cough, ACE inhibitors or ARBs? Drop your answer in the comments. ACE inhibitors and ARBs share some common side effects and contraindications. We'll discuss these, including the first dose phenomenon and angioedema. The first dose phenomenon can cause sudden dizziness or fainting due to a rapid drop in BP, so these are often taken at bedtime. Angioedema is rare but life-threatening swelling, usually around the face and throat. Also, never give these in pregnancy. They're category D. Hyperkalemia is a potential side effect of ACE inhibitors and ARBs. We'll review the signs and symptoms of this condition. Hyperkalemia is elevated potassium in the blood. Signs include muscle weakness, fatigue, nausea, and serious ones like heart rhythm changes. Nurses should monitor potassium levels and avoid potassium-rich foods or supplements while on these meds. Calcium channel blockers work by blocking calcium ion channels. We'll discuss their mechanism of action and their indications for hypertension and other conditions. Calcium is needed for muscle contraction, including the heart and blood vessels. By blocking calcium channels, these drugs relax arteries, lower BP, and reduce the heart's workload. They're used for hypertension, angina, and some arrhythmias. We'll examine specific calcium channel blockers, including their routes of administration, dosages, and potential adverse effects. Drugs like amlodipine, nifedipine, and verapamil are common examples. They can be taken orally, sometimes IV in emergencies. Adverse effects include peripheral edema, constipation, flushing, and dizziness. Verapamil and diltiazem may slow heart rate, so monitor. Calcium channel blockers have a variety of effects on the heart and blood vessels. We'll explore these effects and their clinical implications. Some are more heart-focused, non-dihydropyridines like verapamil. Others are vessel-focused, dihydropyridines like nifedipine. This affects which patients you give them to, e.g., verapamil for arrhythmias, nifedipine for high BP. Calcium channel blockers can be divided into dihydropyridines and non-dihydropyridines. We'll discuss the differences between these two types. Dihydropyridines, e.g., amlodipine, mostly dilate blood vessels, causing less impact on the heart rate. Non-dihydropyridines, e.g., verapamil, diltiazem, affect both vessels and the heart's conduction system, used for rate control in arrhythmias. If your patient has a history of bradycardia, would you give verapamil or amlodipine? Comment your answer. Let's take a closer look at nifedipine, a common calcium channel blocker. We'll discuss its actions, uses, and potential adverse effects. Nifedipine works mainly on peripheral arteries, reducing BP quickly. But watch out, it can cause reflex tachycardia, flushing, and ankle swelling. It's great for angina and hypertension, but avoid crushing the extended release form. When administering calcium channel blockers, there are several important nursing considerations. We'll review these, including monitoring ECG and blood pressure. Always get a baseline BP and HR. Watch for hypotension or bradycardia. Avoid grapefruit juice. It increases drug levels dangerously. Educate patients to report swelling, slow HR, or dizziness. Be especially cautious in older adults. Your patient takes amlodipine and reports swollen ankles and dizziness when standing. What would you assess next? Leave your thoughts below. Calcium channel blockers can cause a range of adverse effects. We'll discuss some of the most common side effects, such as flushing and edema. These side effects happen because the blood vessels are relaxing and widening, which can lead to pooling of blood in the lower extremities, causing edema, and increased blood flow near the skin, causing flushing. Constipation, headache, and dizziness are also common. If your patient complains of ankle swelling or puffy hands, what's your first move? That's your cue to reassess fluid retention and possibly adjust the dose. Diuretics are often used to treat hypertension and other conditions. We'll review the different types of diuretics and their potential side effects. Diuretics help lower BP by reducing fluid volume in the body. There are three main types: thiazides, like HCTZ, loop diuretics, like furosemide, and potassium-sparing, like spironolactone. Each works in a different part of the nephron and has unique effects on electrolytes. Adrenergic receptors play a key role in blood pressure regulation. We'll summarize the effects of alpha-1, alpha-2, beta-1, and beta-2 receptors. Alpha-1 receptors cause vasoconstriction. Alpha-2 receptors reduce sympathetic output. Beta-1 receptors in the heart increase HR and force. Beta-2 in the lungs cause bronchodilation. Blocking or activating these can drastically affect BP and breathing. Alpha-1 adrenergic antagonists block sympathetic receptors in arterioles. We'll discuss their indications and important nursing considerations. These meds, ending in zosin, like doxazocin, relax blood vessels, and are especially helpful in older men with hypertension and BPH, but they can cause the first dose phenomenon, a sudden drop in BP, leading to dizziness or fainting. Let's take a closer look at doxazocin, an alpha-1 adrenergic antagonist. We'll discuss its actions, uses, and potential adverse effects. Doxazocin is used for both hypertension and benign prostatic hyperplasia, BPH. It helps improve urine flow while lowering BP. Side effects: orthostatic hypotension, dizziness, fatigue, and possible reflex tachycardia. When administering adrenergic antagonists, there are several important nursing considerations. We'll review these, including monitoring vital signs and ECG. Hold the medication if the HR is below 60 or BP is below 90 to 60. Watch for rebound hypertension if the drug is stopped suddenly. Beta blockers may hide hypoglycemia symptoms in diabetics, so close blood sugar monitoring is crucial. Your patient's BP is 88/60 after taking an alpha blocker. What do? A. Give OJ. B. Hold the med and call the provider. C. Recheck in 4 hours. Comment with the correct letter. Alpha-2 adrenergic agonists decrease sympathetic nerve impulses from the CNS. We'll discuss their uses, adverse effects, and administration considerations. These drugs, like clonidine and methyldopa, work centrally in the brain to reduce BP. They're often used when other meds don't work, or during pregnancy, methyldopa, but they can cause sedation, dry mouth, bradycardia, and rebound hypertension if stopped abruptly. Beta blockers affect beta receptors in the heart and lungs. We'll discuss the different types of beta blockers and their receptor selectivity. Cardioselective beta blockers, like Metoprolol, target only beta-1 receptors in the heart. Non-selective ones, like propranolol, also block beta-2, which can cause bronchospasm, so avoid in asthma or COPD patients. Beta-1 adrenergic blockers work by blocking beta receptors in the heart. We'll discuss their actions, side effects, and indications. These drugs slow the heart rate, reduce the force of contraction, and lower BP. They're used for hypertension, angina, heart failure, and post-MI. Side effects: bradycardia, fatigue, depression, sexual dysfunction, and potential masking of hypoglycemia. Beta blockers are categorized based on their receptor specificity. We'll review cardioselective, mixed alpha-beta, and non-selective beta blockers. Cardioselective, e.g., atenolol, metoprolol, are preferred for patients with respiratory issues. Mixed alpha-beta blockers, e.g., carvedilol, labetalol, provide both heart rate reduction and vasodilation, great for heart failure and pregnancy-related hypertension. Non-selective, e.g., propranolol, can affect both heart and lungs. Let's take a closer look at metoprolol, a common beta blocker. We'll discuss its actions, uses, and potential adverse effects. Metoprolol selectively blocks beta-1 receptors in the heart. It slows the heart rate, decreases contractility, and reduces oxygen demand, making it a go-to drug for hypertension, heart failure, angina, and post-MI management. What vital sign do you check before giving metoprolol? Leave your answer below. We'll continue our discussion of metoprolol, focusing on administration alerts, contraindications, and pharmacokinetic properties. Always check the apical pulse for 1 full minute. If it's less than 60 bpm or BP is under 90-60, hold the dose and notify the provider. Be careful in patients with asthma, COPD, or diabetes. It may mask hypoglycemia. When administering beta blockers, there are several important nursing considerations. We'll review these, including assessing apical pulse and monitoring blood pressure. Monitor for signs of heart failure, shortness of breath, weight gain, edema, and fatigue. Assess for depression or decreased libido. These are often underreported. Educate patients not to crush extended release forms and to rise slowly to prevent dizziness. Hydralazine is a direct-acting vasodilator used for hypertension and heart failure. We'll discuss its actions, uses, and potential adverse effects. Hydralazine relaxes arterial smooth muscle, lowering resistance and reducing afterload. It's typically used in resistant hypertension or heart failure, but it comes with serious risks: reflex tachycardia, lupus-like syndrome, and fluid retention. Now, let's shift our focus to drugs used to treat heart failure, another significant cardiovascular condition. Heart failure means the heart can't pump enough blood to meet the body's needs. Over time, the heart becomes weak, stiff, or enlarged. Medications help reduce the heart's workload and improve efficiency. Let's talk about how we help a tired heart beat stronger and smarter. Heart failure is the inability of the ventricles to pump enough blood. We'll discuss the goals of drug therapy for heart failure. Our goals: slow the heart rate, reduce preload and afterload, block harmful neurohormonal pathways like RAAS, and increase contractility when needed. Each drug class plays a unique role in this process. Several classes of medications are used to treat heart failure. We'll provide an overview of these different drug classes. These include ACE inhibitors, ARBs, beta blockers, diuretics, cardiac glycosides like digoxin, SGLT2 inhibitors, ARNI like Entresto, and vasodilators. Most patients are on a combination depending on their stage of heart failure. Cardiac glycosides, such as digoxin, increase the strength of myocardial contraction. We'll discuss their mechanism of action and potential adverse effects. Digoxin increases intracellular calcium in heart cells, boosting contractility and slowing conduction through the AV node, ideal for patients with HF and atrial fibrillation. But the therapeutic window is narrow. Digoxin toxicity can be a serious concern. We'll review the symptoms of digoxin toxicity, including cardiac, GI, and neurological manifestations. Toxicity symptoms include irregular heartbeats, bradycardia, nausea, vomiting, confusion, and vision changes, like seeing yellow-green halos. Monitor serum digoxin levels 0.5, 2.0 ng/ml, and potassium. Hypokalemia increases toxicity risk. Phosphodiesterase inhibitors, such as milrinone, increase myocardial contraction force. We'll discuss their mechanism of action and potential adverse effects. Milrinone blocks the enzyme that breaks down CAMP, leading to stronger contractions and vasodilation. It's used short-term for severe HF, especially in ICU settings. Side effects include ventricular dysrhythmias, hypotension, and hypokalemia. We'll review the different categories of drugs used to treat heart failure, including ACI, ARBs, SGLT2I, ARNI, and diuretics. Each of these drug classes targets a different piece of the heart failure puzzle. ARNI, like sacubitril valsartan, Entresto, block harmful hormones and enhance protective ones. SGLT2 inhibitors like dapagliflozin and empagliflozin, originally diabetes drugs, help the heart by reducing preload, afterload, and improving glucose control. Let's summarize some key concepts related to blood pressure and hypertension. We'll review the factors that control blood pressure and the consequences of uncontrolled hypertension. Remember the three major players: cardiac output, peripheral resistance, and blood volume. If hypertension isn't managed, it leads to heart failure, stroke, kidney failure, and vision loss. It's called the silent killer for a reason. We'll continue our summary of key concepts, focusing on the potential adverse effects of different drug classes used to treat hypertension and other cardiovascular disorders. Which drug class causes angioedema and should be stopped immediately? Comment with your guess. We'll conclude our summary with nursing interventions for patients on antihypertensive medications. We'll discuss important teaching points and monitoring parameters. Monitor BP before giving the drug, and teach patients to rise slowly. Educate on side effects like dizziness or fatigue, and stress the importance of daily weights for fluid changes. Watch for symptoms of heart failure or hypoglycemia if the patient has diabetes. Now, let's discuss drugs used for angina and myocardial infarction. We'll define these conditions and outline the goals of drug therapy. Angina is chest pain from temporary lack of oxygen to heart tissue. MI is more serious, a complete blockage causing cell death. Drugs aim to reduce the heart's oxygen demand, increase supply, and prevent clot formation. Drugs used to treat angina work through various mechanisms. We'll explore how beta-adrenergic antagonists, calcium channel blockers, and organic nitrates affect the heart. Beta blockers slow the heart and reduce oxygen demand. Calcium channel blockers relax arteries. Nitrates dilate both veins and coronary arteries, reducing preload and allowing better oxygen delivery. Organic nitrates promote the formation of nitric acid, leading to vasodilation. We'll discuss their uses in treating angina and myocardial infarction. Nitric oxide relaxes smooth muscle, improving blood flow to the heart. Nitrates reduce chest pain and myocardial workload. They're used both short-term, acute episodes, and long-term, preventive. Nitroglycerin is a common organic nitrate. We'll discuss how to take nitroglycerin and the importance of avoiding erectile dysfunction drugs. Let's take a closer look at nitroglycerin, including its actions, uses, and potential adverse effects. Carcins, vasodilation, uses, angina, MI. Adverse effects: headache, hypotension, flushing. Long-acting forms, like patches, require nitrate-free intervals to prevent tolerance. Reteplase is a thrombolytic drug used to dissolve clots. We'll discuss its actions, uses, and potential adverse effects. Reteplase works by dissolving fibrin in clots. It's given IV during acute MI to restore blood flow, but it comes with a bleeding risk. Watch for bruising, nosebleeds, or GI bleeding. Avoid unnecessary injections or catheterizations during use. Several adjunctive drugs are used in the treatment of acute myocardial infarction. We'll review these medications and their roles in managing this condition. Adjuncts like aspirin, antiplatelets, e.g. clopidogrel, nitrates, beta blockers, ACE inhibitors, and morphine all play roles. They reduce clot formation, stabilize plaque, and ease the heart's workload. Dysrhythmias are defects in the generation or conduction of electrical impulses in the heart. We'll discuss the goals of drug therapy and non-pharmacologic treatments. Arrhythmias can cause the heart to beat too fast, too slow, or irregularly. Treatment aims to restore normal rhythm and prevent clots or sudden cardiac death. Cardioversion, pacemakers, or ablation are used if meds aren't enough. Anti-dysrhythmic drugs have a narrow margin between therapeutic and toxic effects. We'll discuss their mechanism of action and classification. Always monitor ECG, HR, and BP. These meds can cause or worsen arrhythmias. Shock is the inability of the cardiovascular system to send sufficient blood to vital organs. We'll discuss the goals of drug therapy for shock. Shock can stem from blood loss, infection, allergy, or heart failure. Goals: restore circulation, improve perfusion, support blood pressure, and correct the cause, like sepsis or bleeding. Your patient is pale, cold, hypotensive, and tachycardic. What do you suspect? Hint: starts with S. We'll explore the background, subcategories, causes, and signs and symptoms of shock. Low BP, high HR, confusion, cold, clammy skin, weak pulses. In shock, initial treatment priorities focus on the ABCs of life support. We'll discuss these priorities and their importance. Always secure the airway, support breathing with oxygen, usually a non-rebreather mask, and stabilize circulation with IV fluids, vasopressors, and cardiac monitoring. Drugs for shock include IV therapy and vasoconstrictors. We'll discuss these treatments and their potential adverse effects. IV fluids like crystalloids, normal saline, or colloids, albumin, help restore volume. Vasoconstrictors like norepinephrine and dopamine increase vascular tone. Side effects include hypertension, dysrhythmias, and extravasation injuries. Epinephrine and norepinephrine are important vasoconstrictors used in shock. We'll compare their effects on the body. Epinephrine stimulates alpha and beta receptors, boosts HR, BP, and bronchodilation, great for anaphylaxis and cardiac arrest. Norepinephrine mostly acts on alpha receptors to raise BP, commonly used in septic shock. Let's take a closer look at norepinephrine, including its actions, uses, and potential adverse effects. Also called Levophed, norepinephrine causes potent vasoconstriction. It's used in shock when fluid resuscitation isn't enough. Must monitor BP closely. Risks include limb ischemia, dysrhythmias, and tissue necrosis if it leaks from the vein. We'll also examine epinephrine, including its actions, uses, and potential adverse effects. Epinephrine is used in cardiac arrest, anaphylaxis, and severe asthma attacks. It's fast-acting and life-saving. Side effects include tremors, anxiety, hypertension, and palpitations. 1 mg IV push every 3-5 minutes during a code. Know it, practice it. Inotropic drugs, such as dopamine and digoxin, increase the strength of myocardial contraction. We'll discuss their uses in shock. Dopamine works dose-dependently. Low doses dilate kidneys. Moderate doses increase contractility. High doses cause vasoconstriction. Digoxin strengthens contractions but acts slower, more useful in chronic HF. Let's take a closer look at dopamine, including its actions, uses, and potential adverse effects. Dopamine supports BP and cardiac output. Monitor for arrhythmias, hypertension, and infiltration risks. Always use an infusion pump and check IV site regularly.